That sounds good.
There's a lot of people entering.
Good morning, everyone.
Good morning, everybody. I'm Sally from the Office of Tribal Relations. You are in breakout session number 1, session B, Fentanyl and Xylazine Trends and Clinical Impact with Gina Cooper. She is the Director of Toxicology at DrugScan, Inc. Prior to working at DrugScan, Gina was in nursing leadership at Community Physician Network in Indianapolis, Indiana, a network of over 200 physicians in more than 80 clinics where she oversaw opioid stewardship and educated providers on prescribing laws and guidelines for controlled substances. Gina was the head of clinical toxicology at the American Institute of Toxicology with expertise in toxicological interpretation and best practice use of toxicology testing for quality clinical outcomes. Gina is a practicing registered nurse with expertise in pain management and substance use disorders. Gina has participated in many harm reduction initiatives, including leading over 20 community-based overdose awareness classes with the naloxone administration training. She earned her bachelor's in biology, nursing, and holds a master's degree in nursing and is a board certified nurse executive. Welcome, Gina Cooper.
Well, thank you.
Also, just to let everybody know, I'll be monitoring the chat. If you have any questions, you can put them in the chat room and we can answer them maybe as we go or at the end of the session. But welcome, Gina Cooper. Glad to have you.
Thank you, Sally. I appreciate that. Thanks so much for having me and having DrugScan be a part of the conference today. I have some objectives up on the screen, so this is what I hope to touch on throughout the next 45 minutes or so, but we're going to highlight some of the unique characteristics of fentanyl that create the clinical challenges that you're probably seeing with your patients. We're going to talk about trends in illicit opiate use that have led to adulteration with drugs like xylazine and other adulterants. We'll talk about the availability and prevalence of xylazine in the United States and how it came to be so prevalent. We'll also talk about legislative changes with xylazine because there have been a few. Some are state specific and there is some new federal information on the horizon as well. We want to talk about clinical presentation of our patients and how they present when they're using this combination of fentanyl and xylazine because it is a little bit unique from other illicit compounds that we see our patients be exposed to. And then we'll talk about some co-positivity, both in terms of our in-house data as we track positivity, and then some of what we're seeing in the literature as well. So just pulling up a little bit and doing a reminder, I think everyone's very familiar with this, but we are on the third sort of wave of opioid overdose. We started out seeing a spike in overdose deaths related to prescription opioids, some of those synthetic, some not, but prescribed nonetheless. The second wave was really in large part due to heroin use and heroin overdose. And then for about the past, probably since 2013 or so, so about 10 years, we've really been dealing with this rise in overdose deaths related to synthetic compounds. And that's driven, for the most part by fentanyl and its analogs. But what we've really seen is since probably around September of 2021, the DEA really got on board. They started this One Pill Can Kill campaign. You're probably familiar with it. But this is in response to fentanyl, for the most part, just fentanyl. We see, you can see some of the headlines that are on the screen, but in large part, these are tablets a lot of people are exposed to. They don't realize it's fentanyl a lot of times. And that has been problematic for people in terms of just morbidity and mortality. We're going to get into that here in just a minute. I wanted to highlight some of what we're seeing specific to Washington. There was some activity, I said about 10 years we've been dealing with this kind of rise in fentanyl use. And you guys, in Washington, there was kind of a flurry of activity starting around 2013, but it's really picked up in the state of Washington since 2019. That's where you see the big kind of spike there on the graph. So we saw your steep rise there in 2019, and it's really continued to rise since that time. This graph is showing you information through 2022. However, preliminary data for 2023 that I've seen that's just starting to kind of trickle out, those trends have continued. So here in 2024, when that's officially published, I think you should expect to see those numbers continue to rise. And so from a toxicological standpoint, as we, spend our time studying what the body does to the drug, what the drug does to the body, there are a few, unique characteristics with fentanyl that really lead to the clinical presentation that you're probably seeing with your patients. So I'll first highlight what those characteristics are, and then we'll get into a little bit about what we're seeing in the clinical space that's a result of this. And so my purpose here is not to bore you with the pharmacokinetics of fentanyl, but they are important here. So we'll touch on just the four that are on the screen there. So whenever we study drugs from a toxicology standpoint, it really is about what we call ADMEs, the absorption, the distribution, the metabolism of the drug, and then finally its elimination or excretion from the body. So to start with, the absorption of fentanyl is unique. Fentanyl is a highly lipophilic drug. You probably heard that by now. And what it really means is that it's readily absorbed into the surrounding tissues, primarily adipose tissue or fat. That's where it does seem to be most at ease. So whenever a dose of fentanyl is, injected, for example, we tend to see the bulk of that reside there in the adipose tissue for a period of time. And I'll kind of show you what that looks like here in a little bit. But it's great that we know that, right? It's great that we know that fentanyl goes there and starts there and ends up in those tissues. But the problem that we run into is that we really have a pretty unpredictable release from the tissue back into the blood and out into the urine, which is probably how you're trying to monitor your patients, is through the use of urine drug testing. So it can be somewhat unpredictable. We can see prolonged detection windows because of that. And it's very difficult to then discern what is reuse of a drug versus what is just something that's finally working its way out of the body. So absorption, number one, characteristic that causes problems for people who use drugs that are fentanyl or fentanyl analogs. Distribution, number two. I'll just point out for distribution, about half an hour after a dose of fentanyl is injected, about 17% of that is detectable in that fat tissue like we just talked about. And the levels in fat are already about 35% higher than what you would find in the plasma. So when fentanyl is used, there's a pretty sharp spike in the plasma concentration in the blood, but it does tend to trail off pretty rapidly, and then that's when we can start to see it in those other tissues. So that typically means that patients, the drug is still in the body, but they feel the need to dose again. To take more fentanyl. And so we see use patterns really escalated from when we moved from heroin into fentanyl. So that's a second thing to keep in mind. Third, I would say metabolism is unique for fentanyl. The majority of the drugs that you're probably concerned with as you monitor patients, and the drugs that I study as well, are metabolized in the liver and what we call the CYP450 enzyme system. And it's really just a series of enzymatic pathways, and everyone's are a little bit different, which also means that individual metabolism plays a big part here. And it can make some of the excretion patterns for some patients a little bit unpredictable, which is difficult for providers or anybody really who's doing that interpretation on the back end. So everyone's pathways, like I said, a little bit different. So keep that in mind. I wouldn't compare patient to patient if you're using urine drug testing. And then I would also say the likelihood of drug-to-drug interactions becomes really important here because, again, the bulk of the drugs that have abuse potential that we're studying, that we're seeing trends with right now, use trends with, are going to be metabolized in the liver. And so again, we can see those drug-drug interactions. And then finally, elimination from the body. When we were dealing with pharmaceutical grade fentanyl versus illicitly manufactured fentanyl, we knew that we could eliminate a dose of fentanyl from the body in about 72 hours. So, a couple of days after the person last uses the drug, we expect those urine results to be negative. And I think we all felt very good about that, right? Because it was well documented in the literature. We could multiply it out based on half-life. It was data we were all very comfortable with using and quoting. Illicitly manufactured fentanyl is a little bit different. We see, again, these use patterns are much different than we saw even with heroin. Patients really feel the need to dose more often. So, repeated exposure nonstop throughout a 24-hour period can lead to that peripheral accumulation, which leads to longer detection windows. So if you're expecting your patient's detection windows to look like pharmaceutical grade fentanyl used to look, that's not what you're going to find anymore. You're going to see these prolonged detection windows. And I'm going to show you kind of what you can expect here in just a second, and I'm happy to share a literature with you guys too, if that's helpful. The last thing I want to point out for kind of these unique characteristics of illicitly manufactured fentanyl and pharmaceutical grade fentanyl is this phenomenon of secondary peaking. And it doesn't happen in all patients, but there is a subset of patients that have this, what we call secondary peak. So typically, someone uses a drug, the plasma concentration peaks and then starts to fall. And somewhere down here would be a trough level. And if they dose again, you would see that trend continue. If they don't use again, you'd eventually hit zero. But with secondary peaking, you hit a peak and then the blood concentration begins to fall. And then for kind of reasons we don't fully understand, it can peak again. And the reason I share that with you is because if you're imagining a scenario where you're in an overdose situation utilizing naloxone to reverse that overdose, this is something that would be very important to know. It can certainly increase the lethality of the drug. So if you have given naloxone to someone who has come back to, there's a lot of situations where, the patient goes back out and needs another dose of naloxone. This would just be one example of a reason why. But it's, again, just something to keep in mind. Doesn't happen with all of your patients, but again, if you're in an overdose situation, just something to be aware of. So because of these special pharmacokinetic characteristics that we talked about, some treatment changes have really been necessary in the clinical setting. So patients who are fentanyl exposed and they can have a high risk of what we call a precipitated withdrawal. And I'm sure most of you are clinical and are familiar with this, but if you're not, a precipitated withdrawal really just means that, in short, the medications that we typically would use to treat withdrawal symptoms actually cause a sudden onset of withdrawal symptoms instead. And that can make patients very uncomfortable, of course. It's very difficult to reverse in a clinical setting. But I think the most important thing to point out about a precipitated withdrawal is that, it can really be a barrier for patients to seek treatment in the future. And of course, what we know about substance use disorders is there tend to be lifelong illnesses with periods of active disease, periods of a remission. And so what we need is patients to not have such a horrible experience in treatment that it's a barrier for coming back whenever they need it, throughout the trajectory of the illness. So that can be problematic for sure. But these treatment challenges have really led many practitioners to change their induction patterns. If you're using buprenorphine, if you're using, Suboxone, for example, And I have some examples on the screen. This is just one example. I'm not a prescriber, but work with several physicians. And so I've just put an example on there. But I think what they've done is tried to move to a place where they don't start buprenorphine unless the severity of withdrawal symptoms is higher than they otherwise would have. They start with lower doses with shorter dosing intervals. And of course, they only continue that dosing if the patient is responding well. Sometimes that also includes more of a naloxone challenge. So I tell you that just to say that what we're seeing happen in the clinical space, the treatment of what we're seeing has started to change. We so far don't have kind of a best practice guideline. There's no, nobody has come out and said, hey, if the patient is fentanyl exposed, this is what your induction is going to look like. So far, we don't have that. We have a lot of providers out there who are sharing their experience, who have gotten creative with dosing, had some positive outcomes, and are starting to share their work, both kind of anecdotally and in some of the literature studies. So that's nice. But still, so far, we don't really have, a best practice to kind of lean on. As I mentioned, fentanyl detection windows are very prolonged because of, the illicitly manufactured fentanyl, the pharmacokinetics that we talked about, and the use patterns. And I just want to show you here on the screen. I hope it's big enough you can kind of see, but the range of detection for fentanyl and norfentanyl has been, like I said, for pharmaceutical grade was about 72 hours. Maybe you could be, generous and say 1 to 4 days, somewhere in that range. Here, this is showing norfentanyl out positive up to 26 days in the urine, which is significant. So this is a pretty limited study. The N is 12, but I'll tell you, the reason I went searching for literature is because it's what we were seeing and hearing from clinicians. So in this particular case, we had a justice involved individual. There were children involved and custody arrangements that were on the line, and the patient was in a locked facility, and they had turned the place upside down looking for fentanyl multiple times as a result of the urine drug screen results that they were seeing, and couldn't find any fentanyl. Patient appeared to be doing well in her early recovery as well, wasn't appearing to be under the influence at all. And so when they called, they were just saying, is there any way, is there anything else I should be looking at? And anyway, I turned to the literature. This is from 2020. So I got a hold of this in probably 2022, but I've been sort of sharing it with anybody who will listen, because I think, this is a vulnerable patient population a lot of times, and we don't want to get it wrong, of all places to get it wrong. And so if we can have someone, 26, 30 days positive since the last use, that's something that we need to know if we're used to saying, no, about 72 hours. So this is significant. You can see the source on the bottom, so you can either screen grab that and get a copy online, or I'm happy to share the full study with you guys as well. But the biggest reasons behind this are going to be the fentanyl absorption, the fentanyl distribution that we talked about just a few minutes ago. And then again, the use patterns are significant here. So the biggest trend that we've seen in opioid use so far, I would say, has been the move from heroin use to fentanyl use. We do still track at DrugScan the positivity rates for heroin metabolites as compared to fentanyl. We do still see a little bit of heroin, nothing like we used to see. I mean, it's vastly different in terms of positivity rates. So I won't say it's gone, but there are parts of the country where we're just not returning positives for heroin anymore, and it's all really moved to fentanyl. So I'd say that's the biggest shift that we've seen in this opioid epidemic. But Xylazine, I'll say, is going to be a close second. If you're not familiar with Xylazine, it is a sedative used in the veterinary space. It is approved for use in the veterinary space. It's legal to use for those providers to use in treatment of their non-human patients. It is nicknamed on the human side, nicknamed Trank or Trank Dope, and I've been asked this question twice, so I'm going to say it. It's I'm not advocating for it. It's the most stigmatizing language I can imagine, but people have asked me, is this the zombie drug? And this is what the news and media have termed the zombie drug. So yes, if you hear that, they're referring to Xylazine. It is not controlled under the Controlled Substances Act, so keep that in mind. We're going to talk about that in just a minute and why it's, the biggest problem with Xylazine is that it's not technically a controlled substance, but it is used increasingly as a cutting agent in the heroin, the street grade fentanyl, and all of that. And I think the biggest reason why, again, what we heard from people who use drugs repeatedly is, when they moved from heroin to fentanyl, they really felt the need to dose more often. And so they were spending the bulk of the day trying to stave off withdrawal symptoms in a way that they didn't have to with heroin. That was still part of their, that was still part of the problem with heroin, but fentanyl kind of, they saw that really, they needed to use multiple times throughout the day. And so I think Xylazine really prolongs the sedative effects of opioids. So that's kind of one benefit of having it as an additive to the drug supply. And it really staves off withdrawal symptoms while someone looks for their next ability to be able to use the fentanyl. Xylazine is not an opioid. It's an alpha-2 adrenergic agonist, which is a long word, but really just means that it decreases sympathetic outflow and your patient is going to be sedated or have, pretty heavy sedative-like effects if they are exposed to Xylazine. So Xylazine, as you can see on the screen, it's similar to other imidazoline compounds. And I put some of those up there because I think if you're in the clinical space, you're probably really familiar with some of the drugs that are on there, specifically the clonidine. I think we use that in probably every clinical setting, not just the substance population, but every setting. But you can see just how similar the structures of all three compounds are. And that usually means that their function is going to be similar as well. The typical, I mentioned the sedation, that's the big one. If you think of Xylazine, you should think about sedation. I would also mention dizziness. These patients are often pretty dizzy to the point of nausea, and skin lesions, which we'll talk about here in just a few minutes, but they have some pretty large surface area skin lesions that can lead to secondary bacterial infections, and they can be pretty problematic to treat. There have been some pretty conflicting reports, I would say, on respiratory effect of Xylazine. People, because it has increased the lethality of opioid overdose, I think people expect there to be an effect on breathing. The data is pretty back and forth on what the effect on breathing is for Xylazine. So far, Xylazine is always present with other drugs, primarily opiates. And I'm going to show you those positivity trends here in just a few minutes. But typically we see Xylazine present with fentanyl or another opiate. So there is going to be an effect on respiratory rate just because there's an opioid on board. I think the biggest thing we see with Xylazine is that, patients are very heavily sedated and they don't arouse to airway occlusion. So, when someone is sedated, the tone of the airway can get a little sloppy and they fail to arouse to that. And that can be problematic again, especially considering that they probably have some respiratory depression related to the opiates that are on board. So as I mentioned, Xylazine is not an opioid, but I wanted to share this brand new information that just came out. This was from September, a literature piece that came out in September that's claiming that in a study that they had conducted, xylazine is agonizing the kappa opioid receptor. If that's the case, then the naloxone would have some efficacy during an overdose situation. So again, this is just one study. It's brand new information. We're all kind of still processing it. They haven't changed the drug classification of xylazine. It's still not an opioid, but just keep in mind that there may be some activity at one of the opioid receptors that could mean that that naloxone has some efficacy during an overdose situation. And so, we've always said, give the naloxone, no matter what, if you know what's going on or you don't know what's going on with the patient, just give the naloxone. And so I'm glad that that's been our message throughout, because it looks like we may see some efficacy with xylazine as well.
Hey, Gina.
Hi,
Yeah.
Gina.
Sorry, do you mind if I jump in for just one
sorry.
second? There was
Yeah.
a question in the chat, and I think it was from several slides ago. So I didn't know if we could go to that, or
Tell me
So-
when to.
sure. It says Miles asked, what would the numbers look like on a screening around 10 to 15 day test time frame? So I'm not sure where that one was, but
I'm assuming for fentanyl, when we were talking about the longer detection windows.
where's Miles? I don't know either.
Okay. Well, let me say a few things about urine results, and then Miles, if you want to stop me if I'm on the wrong track here with your question. But the longer post last use, the lower we expect the urine concentration to be. However, it also depends on how high it was when we started the testing. So if I do a urine screen on someone today and it's 10,000 nanograms, then I should expect in 8 days, it's probably not 12,000 nanograms. It's probably somewhere down around 5,000 or 6,000 nanograms. But there are several, urine drug screening is tricky because there's a lot of variables present in the interpretation. So we've got hydration status and individual metabolism, pH of the urine, other compounds the patient is taking that would induce or inhibit metabolism of the drug that we're actually looking at. So it just depends, but I'll tell you, you would expect it to go down every time you draw or every time you do a specimen collection of the patient. If you're seeing it kind of bop up and down a little bit, I would adjust for creatinine so that you can remove that variable, how concentrated or how diluted is my specimen. If you adjust for your creatinine, that can kind of help you to minimize the effect of that variable. And that's something that, a toxicologist can help you with. If you've done testing on a patient, you probably have, a phone number you can call and someone can help you to adjust for or normalize for your creatinine. So we don't, in blood, you can look at a result and say, you can kind of back into a calculation and say, this is probably when they used and how much they used, but urine, that's not a calculation that we can perform. So it gets a little bit tricky. You kind of have to put all the pieces in a pile and then start to kind of navigate and see what heads or tails you can make. But I would start with normalizing for creatinine. Did we hear back from him? I haven't been watching the
No, I believe that is the question he asked that you answered, but thank you.
Okay, great. I wanted to show just the prevalence trends for xylazine starting back in 2019. Doesn't mean that's when it arrived on the scene. It means it's when we started looking for it or testing for it. Which is a limitation of the data, as you can imagine, is that the states have to be looking for it. But in 2019, we first saw xylazine in Puerto Rico, and then we saw it next in Pennsylvania. which is an interesting leap in my mind, but that's where we saw it move to, was that Philadelphia area, which Philadelphia is kind of famous for their Kensington Avenue, oftentimes referred to as Kensington Beach, and all of us from DrugScan are very familiar with it because our primary lab, we're a nationwide company, but our primary lab space is in the Philadelphia area. And it is about 40 minutes from one of the largest open air drug markets in the world there at Kensington. And so probably that's where we made the leap from Puerto Rico to Pennsylvania. But you can see kind of hit there in that Northeast region in 2019, a little bit in the Midwest. Here's 2020. So we went from 8 states in 2019 to about 29 states in 2020. And then here's 2021. This is the most recent graph that I've pulled from here, but we have continued to even help with reporting data from positives throughout the country for clients that we serve and health departments that we've worked with. And I can tell you that we've seen it pretty much coast to coast at this point. Any states where we don't have reported positives, they haven't been looking for it. So it's pretty much a nationwide issue at this point. And then just quickly, I wanted to show you that there is kind of a strange divide there. You can see where it goes from the darker colors to the lighter colors in the western half of the United States. While we know that the western half is seeing positive xylazine, we know the numbers have kicked up, but you are pretty far behind from the other half of the country. So your positivity rates are some areas about 15%, some are less than 15%, whereas the other half of the country, the numbers have gotten much higher, much faster. So it's in your area. So we expect it to continue to increase, but it just has been a slower uptick than other areas. Like I said, though, Pennsylvania.
Hey, Gina, there's another question in the chat.
Okay. And
it is, what data do you have with impacts in tribal communities?
I don't. I have some of the impact data for Washington specifically, and I know that is it King County? Is that the Seattle area? Is that the county? I know that they've been having special kind of steering committees and meetings that they've invited even news media to. So they have kind of formed their own special coalition to look at fentanyl use trends in that area to see what kind of help they could provide, what kind of mitigation strategies they could put in place. I don't have, and I don't know how much access I have even to, that specific population and the use patterns there.
Okay, thank you.
You can see here on the screen, I'm trying to kind of just paint a contrast from the different areas of the US, but you can see from the graph on the screen that in 2021, xylazine was present in about 35% of the overdose deaths, not alone, but was present together with an opioid. And then you can see here in 2021, about 91% of the samples of heroin and fentanyl from the Philadelphia area also contain xylazine, and that's 2021 data, so 91% 2 years ago. So it's certainly the most common adulterant in the drug supply in that area, and has been problematic ever since. The biggest problem with xylazine, though, really is that it's not illegal to possess. Xylazine can be purchased online without much difficulty. Again, it's not federally controlled in terms of the Controlled Substances Act. I'm going to show you what a few states have done, but it is not federally controlled. When I go online, if I put in, we're pretty familiar with buying, drug reference standards to do our research and development. at our laboratory. And so if I, find the identification number, I go on Google, I put it in, and I can easily find multiple sites where I could go on and purchase xylazine. These all happen to be China sources, but there are many places to buy it. If I clicked start order on the right hand side, I just create an account and I could easily just have it shipped to my home. So it's a very easy thing to get a hold of. Most recently, we have a few states, you can see them listed there on the screen, that have put state-specific xylazine controls in place, which has been, I think it's helpful in terms of monitoring data, seeing what's coming in, where it's coming from. If it's not controlled, nobody's really looking at it. We know it's a problem, but we don't have the resources to really keep track of it if it's not controlled. But these are states that have put at least some sort of, legality around it. And then I also put on here the new bill combating illicit xylazine act. That has been, it's before the House. It has moved to committee, so it's being researched at this point and tossed around, and then we'll see if it eventually makes its way through to be signed into law. But that bill is very careful in its language to make sure that it protects veterinary access to the drug, really recognizes the efficacy in that space while trying to keep it out of the hands of the people who are using it illicitly over on the human side. So in terms of how they present, people under the influence of xylazine, they experience this, like I said, heavy, long-lasting sedation, often very unresponsive, difficulty with their breathing in terms of airway, response to any occlusion, and then the opioid being on board, creating some bradycardia. The overdose becomes very difficult to reverse in these situations. And I would say, I'll point out too, the sedation is really important to point out because it's, again, heavy, long lasting, and it's really created a public health emergency for people who use drugs. Because what we found in reports of just talking to patients is, they buy the drug, they use the drug, and there was someone waiting for them to use the drug and to be sedated so that they could come, they come steal their possessions or rob them. There's people who have aroused finally hours later and said, I was assaulted. I missed the whole thing. I was so out of it, but I was assaulted. And so in terms of just a public health crisis, it's certainly added to that. The treatment has been very complex in terms of severity of withdrawal symptoms. We've got people.
Hey, Gina, can I interrupt again?
Sure.
There's a question in the chat that I'm curious if there's any pushback from any groups on controlling xylazine.
Not that I know of. I know that the veterinary population was very concerned because that for them is one of the most efficacious way to sedate their patients. But again, the wording in the bill that's been presented is very careful to protect their access. I know there was a lot of criticism about why is it so easy to get our hands on it? Why can I go online and order this and have it shipped to my house if it's creating such harm for patients? So I know on the flip side of the question, there has been some criticism about what's taking so long to get this done. But I haven't heard, aside from, again, the veterinary space saying, whoa, hang on a second, this is still something really valuable for us to use. I haven't heard anyone, kind of on the human side saying that they're opposed.
Thank you, Gina.
Yeah, I think in terms of treatment, we've had quite a few patients who said things that were very surprising to us, such as, I was in treatment for 5 days or 6 days and I couldn't take it anymore. And I left treatment, and that's, something we're not used to hearing. Typically 5 days in when a patient comes in for an inpatient detox, 5 days later, we're all thinking about discharging them to a different level of care. They're starting to really be ambulatory on the unit and feel better. And so patients who are xylazine exposed, it's just been a little bit, their withdrawal symptoms are a little bit longer lasting and severe. It's causing these really high recidivism rates in treatment facilities. Again, we don't have a good protocol for detoxing someone who's been exposed to xylazine. There are quite a few providers who are using some sort of marriage of an opiate use detox protocol and an alcohol use protocol, or even a benzodiazepine use detox protocol, which has been really efficacious for a lot of these providers. Some of them have started putting their, just publishing so that their peers can chime in and say, this is what's working for us. And we've learned quite a bit just by reading those reports. But so far, there's really no best practice organization that's come out and said, this is how you perform detox inpatient on a patient who's xylazine exposed. I think the biggest thing we hear about is anxiety. The anxiety is really difficult for patients to get around. These patients are really agitated when they come in for treatment, and that can last, quite a long time, which is not surprising, but, again, lasts sort of days to weeks. Again, we don't have great data on evidence-based treatment recommendations for this, but we do have SAMHSA has put out the statement that's on the screen, and they're not really saying anything we don't already know. I think most of us look at this and we say, well, yeah, well, we already know that. It's already what we're doing. But they just talk about routine opioid care, including naloxone when necessary, counseling on harm reduction strategies, which is great, any kind of MOUD that's appropriate for care of that patient, and then partnering with a tox lab that can, start by helping you identify that xylazine has been on board. Because again, I'm sure you're familiar with how drug testing works, but you can't submit a sample and say, okay, now tell me everything that's in it. You have to tell the lab what to look for. You have to program the instrument and tell it, what to look for. So unless you're specifically, asking a laboratory to look for xylazine, you may not know that it's in there. This is just one example of some of the literature cases we have coming out. These are small N studies, typically kind of almost anecdotal case reports of different providers, how they chose to treat a patient and what the outcomes were. So these are starting to pop up all over. So if you get on, PubMed, this is something you can start reading those case studies, and they can be really helpful.
Hi, Gina. We had another question in the chat about xylazine.
Okay.
Can urine tests pick up xylazine? And also, will you be sharing the harm reduction strategies?
Yes, I will, to both. And I think it's right after this wound slide, we get into the testing, but I'll give you a teaser. It's a specialty test, just like other novel psychoactive drugs that kind of like emerge so quickly on the scene. They require specialty testing. The R&D is expensive, time consuming. So not all labs, get into the synthetic game. It's a lot like chasing your tail, because as soon as you get your assay just right and roll it out, there's something new. And you got to start the process all over again. So it can be tricky, but you can test for it. You just tell it has to be a lab that has that particular test available. And if your lab has that test available and you ask for it specifically, they'll be able to get you that information. DrugScan does test for xylazine. But again, there's so few labs doing it, because you have to really make that commitment that this is where we're going to spend our R&D efforts. So I think DrugScan is one of 2 SAMHSA certified labs in the country that tests for it. And maybe just, I don't know, a couple handfuls of labs total that do the testing. I'm going to show you a report though here in just a minute that has some xylazine positivity on it. But I do want to point out real quick that the xylazine is linked to pretty severe wounds, ulcerations, tissue damage, and the like. These are, I think initially we all wanted to, believe that these were linked to injection sites. But what we've learned is, people saying, hey, I only inject on my hands, but the wounds are all down my legs, or I don't inject, I only smoke, but I am covered, in these wounds. And so there's a lot of research still being done about the wounds, and not just the source of the wounds, but the secondary bacterial infections that in large part have been fairly resistant to antibiotic treatment. So there are some organizations that have gotten funding to start doing some research there. Probably, I think the presumed mechanism for these wounds is going to be that, direct vasoconstriction, probably on local blood vessels, decreased oxygenation, skin, tissue perfusion, hypotension, the bradycardia, all of those things probably are at play here. There has been some early proposals that free radicals are involved here as well. But the complications with these wounds include, severe soft tissue infections, so cellulitis, abscesses, that skin ulceration, impaired wound healing is at play here. So these can really be long lasting, painful wounds. And I'm not going to show you a lot of pictures because it's hard to find pictures that don't have a face in them, number one. And number two, I just never know if someone's going to be eating while we're talking about this stuff. But so I won't show you a bunch of the pictures, but there are many pictures online to kind of give you an idea. If you haven't seen the wounds, go on and look for them so that you kind of have an idea what to look for and which wounds, you think are appropriate to relate back to potential xylazine exposure. But I'll paint you a picture here. It's pretty serious necrosis of the subcutaneous layer of tissue, usually pretty large. You can see there in the arm, pretty large surface areas involved, often complicated again with cellulitis, secondary infections. So MRSA, for example, beta strep. And we can see those infections really take over and lead to other things, endocarditis, for example. But I would say too, keep in mind what this does from a public health perspective as well. It's very difficult to get someone into treatment who has open wounds and secondary infections. A lot of treatment facilities, they don't have the staff, they don't have the wound care equipment and supplies to, be able to treat the wounds. And I would also say, our unhoused population, it's very difficult to get them into any kind of, group shelter type facility when they have wounds like this for the same reasons. They worry about spreading infection. They don't have the supplies. They don't have the staff. So it's very difficult from a public health perspective. One last thing on the wounds, you can see on the screen, soft tissue infections really on the rise, bone diseases and amputations on the rise as well. There's some studies on all of these being done in the Philadelphia area. And so we look forward to seeing what those statistics are. But these are all things, of course, that we know are going on. So to the question we just had, here's an example of a report from DrugScan. We rolled out our xylazine assay in March of 2023. And we've been kind of tracking the trends ever since so that we could, put on data presentations such as this one. What we really expect to see is xylazine in pretty low concentrations in the urine. Certainly it's dependent on the amount of exposure. How long have they been using? How often do they use? How potent is the supply that they've received? All of those things, but we usually do see them in pretty low concentration. So we're using a cutoff of 1 nanogram, and that's been sufficient. Again, it's a new novel specialty test. There's not a lot of labs testing for it. So in terms of getting like a really good snapshot of positivity rates coast to coast. It can be a little bit difficult, so that's why we've chosen to de-identify our data and track it internally. I think, one of the questions we get a lot is, okay, so xylazine testing is available now, so we should all be ordering the test, right? Should we be testing for xylazine? And I'm careful about the response to that for two reasons. Number one, all testing has to be medically necessary, and I'm not the provider. But number two, we as the lab just have to be really careful when we encourage testing. So I'll just say it should be medically necessary. And if you're going to, if the drug test results being positive or negative for xylazine is going to change how you treat the patient, then we absolutely advocate for testing. If it's not, and you say, look, it's always present together with opiates, so I'm going to treat an opiate use disorder. If they're having trouble with their detox, I'll bring in characteristics of a benzo detox maybe to see if that helps. And, I'm not going to treat their wounds any differently, right? Because a wound is a wound no matter what the source. So if that's your kind of line of thinking, maybe you don't need to test for it. Maybe you want to test for it here and there when you suspect, just so that you know what's in your area. That can be really valuable too. So I think it really just comes down to the goal of the provider, what they want to know and how they plan to treat the patient. But the testing is available. The two highest positive states that we have at DrugScan so far are Illinois and Pennsylvania. We only just went live in New York. There's a lot of special, nuances with testing in New York, so it's usually lagging behind. It went live a few months after the rest of the country, so we kind of wait to see, there being in close proximity with Pennsylvania, what that data will look like. But so far it's Illinois and it's Pennsylvania. This is just another example, pretty textbook example. We usually see fentanyl and or norfentanyl positive whenever we see xylazine be positive. We see quite a bit hit that upper limit of 600 nanograms. That's where we've capped our assay upper limit. So it's not unusual to see, patients hit above that upper limit. But again, the lower limit of 1 nanogram has been pretty sufficient for detecting most of these. Here's our early data from DrugScan. 31% of the specimens that came in requesting xylazine were positive for xylazine. 88% of those were paired with fentanyl and or norfentanyl, the metabolite. 73% were co-positive with fentanyl plus either cocaine or methamphetamine, and 59%, and I think I probably had that when they're talking with someone from Illinois, but 59% positive in the Illinois submission. So each state's is a little bit different. Washington's are lower than most of our other states. And I know we talked about that when we looked at the orange and yellow map, so that probably doesn't surprise you, but because again, it's following the fentanyl trend, but you guys are a little bit lower. And so that was DrugScan specific data. This is the literature, published literature, co-positivity with other compounds. Again, we see fentanyl being the big one. So almost 96% of the xylazine positives were also positive for fentanyl. And then I highlighted the heroin just so you can see the vast difference between the heroin and the fentanyl. There's just not a lot of heroin in most parts of the country right now. And then lastly, just to end, I like to end on this harm reduction piece. What we've always said is give the naloxone. That's been the message the entire time, because there's just no harm. If it's not an overdose, there's no harm. If there's not, if this is xylazine with cocaine, giving naloxone, we didn't expect there to be a lot of efficacy. I did point out that there is some new information that suspects maybe there is some at the kappa opioid receptor, but all of that to say, just always give the naloxone no matter what you if you suspect substance at all, because there's no harm. Some providers have attempted to treat xylazine exposure with other alpha-2 agonists, which I know where they're headed with this, and it does make sense. But when you look at, one of the ones that I had on the screen there, clonidine, I don't think we're ever going to find a provider who's brave enough to give enough clonidine to a patient to reverse, xylazine effects for obvious reasons, right? We're going to worry about hypotension and bradycardia and things like that. So it's not widely accepted, but I know there is a little bit of study going on around that. I know there is an organization in the Philadelphia area serving the unhoused in that large open air drug market that I talked about, that are using oxygen, pure oxygen. So when they go out, they've all got naloxone, kits around their necks, and they are wheeling oxygen around. Obviously, we can't all do that. We can all carry naloxone, but we can't wheel around an oxygen tank. But they are anecdotally claiming some pretty good efficacy, giving pure oxygen in those cases. I'm sure it is efficacious. If you're in a clinical setting, that's an obvious thing that we can do that would probably lead to better clinical outcomes. I would also point out there is a drug called atipamezole. It's an alpha-2 adrenergic receptor antagonist, and it is the reversal agent for xylazine. And so you're probably thinking, why didn't you start with that? There's a reversal agent. But the problem with that is that it is also only approved for use in the veterinary population. And some of the early studies that were done to see, hey, is there anything we can do in terms of dosing that would allow us to use it in a human population? There's an awful lot of cardiac things at play there. And I think no one's even doing the research at this point. I think what they found early on was enough for them to say it's simply not going to happen. So it's not being pursued at any concentration for use in humans as an anecdote. So I'll just end by saying always give the naloxone, use what you can, the recovery position, all of those things. If you're in a clinical setting, obviously you can use oxygen, because again, there are some of these boots on the ground organizations that are using just pure naloxone during opioid or during overdose reversals, and they haven't published just yet, but they are claiming some pretty good efficacy when it's a xylazine impacted overdose. So that is all I have, but I'm happy to take any additional questions.
Thank you, Gina. We have about 2 minutes left, and it looks like there's one question in the chat. Is there any connection between xylazine and desomorphine? The necrosis overlap is curious, though it seems like desomorphine spikes in years past were a flash in the pan compared to the emergent xylazine problem.
I'm not sure actually, but agreed. Wounds have long accompanied substance use. And so I think right at first, a lot of it didn't get our attention because I think we thought, well, there's a behavioral component here. Wounds, this isn't new. And then it wasn't until we saw just the how extreme and resistant the wounds were that it got everyone's attention, and we started really studying it and all of that. So I'm not sure, but I do follow the research. And there are 2 studies currently that I've kind of, I've worked closely with the people conducting the studies, and I'm waiting anxiously to see outcomes data. And I am happy to share whatever I find with you guys.
Thank you, Gina. Your presentation was awesome. Thank you for your time. We're glad you came here to present here at our ICYF conference, and we hope to see you again. Just a reminder to conference participants, we are on a 1-hour lunch break from 12 to 1. And at 1 o'clock, we'll start out breakout session 2. Session A is the healing power of Qigong by Shinoa Igawa. And session B is the opioids in juvenile rehabilitation facilities by Dr. Kim Ahrens. So thank you everybody for joining us. Special thank you to Gina Cooper. And we're on the lunch break now.
Sally,
Thank
thank you too. I'm John. I work with Gina at DrugScan, and I'll send out her PowerPoint presentation, all this stuff, so everybody can have it. And any questions, they can follow up with me or Kevin.
Thank you. We appreciate that.